In order to fully learn and understand the concepts of mechanical ventilation, you must first develop the understanding of ventilator settings, that are the input to ventilator machine that determines how much support is provided to the patient. In this video, I want you to walk through all the basic ventilator settings that you must know about as a medical professional. If you stick around the video, subsequently we will discuss how to select the appropriate initial ventilator settings. Let's get into it.
First and foremost, what are ventilator settings? To give a brief definition, ventilator settings are the controls on a mechanical ventilator that can be set or adjusted in order to determine the amount of support that is delivered to the patient. Support can be provided in the form of ventilation and oxygenation. You must develop an understanding of how each setting can be adjusted in order to provide more or less of each type of support for the patient. Some examples of the basic ventilator settings include ventilator mode, tidal volume, the frequency or rate, FiO2, inspiratory flow rate, IE ratio, sensitivity, PEEP, and ventilator alarms. So if you're ready, let's go through each of these settings one by one so that you can truly learn how the machine operates and provides support for the patient. First, we have the ventilator mode. When selecting a ventilator mode, there are two primary control variables, and they are volume control and pressure control. Volume control means that you can set or control the patient's tidal volume. So with a set tidal volume and a set respiratory rate, this means that there is a known minute ventilation. This is good when it comes to making adjustments to achieve a desired PaCO2. One of the negative aspects of using volume control is that since the tidal volume is preset, if the patient's lung compliance were to decrease, this could result in high peak pressures. Another drawback of volume control is patient ventilator dyssynchrony. And then there's pressure control ventilation. Pressure control means that you can set or control the patient's pressure in order to achieve a desired tidal volume. So as with volume control, a pressure-controlled tidal volume and set rate can help you reach a desired PaCO2. The main disadvantage of using pressure control is the patient's tidal volume can potentially be unstable if there are changes in the patient's lung compliance or airway resistance. So again, volume control and pressure control, those are the two control variables. When initiating mechanical ventilation on a patient, once you set the control variable, now you can choose the actual operational mode that determines the pattern of breathing for the patient. Understanding the different ventilator modes is one of the most important aspects of mechanical ventilation. The mode acts kinda like a brain for the ventilator because it tells it how to perform and operate. Some of the common modes that you need to know about include assist control, SIMV, pressure support ventilation, CPAP, volume support, control mode ventilation, airway pressure release ventilation, mandatory minute ventilation, inverse ratio ventilation, and high frequency oscillatory ventilation. When selecting a ventilator mode, you must first determine if the patient needs full or partial ventilatory support. Assist control can be provided if the patient needs full ventilatory support, or if they only need partial support, then SIMV would be recommended. We actually have a full guide and video on this topic that goes much deeper into all the different modes of mechanical ventilation. Tidal volume refers to the volume of air that is inhaled and exhaled from the lungs during normal breathing. The tidal volume setting on the ventilator determines how much air is delivered to the lungs by the machine. If a patient is in a volume-controlled mode, the delivered tidal volume can be adjusted by increasing or decreasing the tidal volume setting. On the other hand, if the patient is in a pressure control mode, the delivered tidal volume can be adjusted by increasing or decreasing the pressure setting. Next, let's talk about the frequency, which is just the technical term for respiratory rate. Or it can even be referred to as the breathing rate because this setting simply controls the rate at which breathing occurs. It typically refers to the number of breaths that are taken per minute, and the normal range is 10 to 20 breaths per minute. So simply put, the frequency setting on the ventilator determines how many breaths are delivered to the patient per minute by the machine. Next up is the FiO2, or fraction of inspired oxygen. This refers to the concentration of oxygen that is being inhaled by the patient. For patients with severe hypoxemia, an FiO2 of 100% may be required when mechanical ventilation is initiated. But your goal as a respiratory therapist should be to wean the FiO2 down to the lowest possible level that still provides adequate oxygenation. If a patient receives an FiO2 of greater than 60% for a prolonged period of time, it increases their chances of oxygen toxicity. So that is just something to keep in mind. Next, we have the flow rate, which refers to the inspiratory flow rate. This setting controls how fast a tidal volume is delivered to the patient by the ventilator. This setting can be adjusted depending on the patient's inspiratory demands. The normal inspiratory flow rate should be set at around 60 liters per minute. With that said, most ventilators can deliver up to 120 liters per minute if a patient needs a prolonged expiratory time. This is necessary when obstructive diseases are present. When it comes to flow rate, one thing to remember is that if it's set too low, it could result in patient-ventilator dyssynchrony and an increased work of breathing. If the flow rate is set too high, it could result in decreased mean airway pressures. The next setting that we're going to talk about is the IE ratio, or inspiratory to expiratory ratio. It refers to a ratio of the inspiratory portion compared to the expiratory portion of the breathing cycle. For patients on the ventilator, the normal IE ratio is between 1 to 2 and 1 to 4. A larger IE ratio may be delivered if a patient is in need of a longer expiratory time due to the possibility of air trapping. If you're needing to adjust the patient's IE ratio, you can do so by making changes to the flow rate, inspiratory and expiratory time, tidal volume, and the frequency. Now let's talk about the sensitivity, also known as the trigger. The sensitivity control is what determines how much effort the patient must generate in order to trigger a breath from the machine. And when I say effort, what I'm really referring to is how much negative pressure the patient must generate for the ventilator to deliver a breath. The normal sensitivity setting should be set between -1 and -2 centimeters of water pressure. If the sensitivity is set too high, it will cause the ventilator to initiate auto-triggering and increase the total frequency of breaths. If it's set too low, the patient could have a difficult time initiating a breath to begin with. So this is definitely something that all of my respiratory therapy students should remember, especially those who are preparing for the TMC exam. Whenever you see a question about a patient who is struggling to initiate a breath, just remember that you likely need to adjust the sensitivity setting. So moving right along, now let's talk about PEEP, or positive end expiratory pressure. PEEP is essentially an amount of positive pressure that is delivered during the expiratory phase of the breathing cycle. It helps prevent the closure of alveoli in the lungs, which allows an increased amount of time for oxygen exchange to occur. This is why PEEP is often recommended for patients with oxygenation issues. In fact, the most common indication for PEEP is in patients with refractory hypoxemia and those who have not responded well to a high FiO2 setting. So let's say you have a patient who is struggling with hypoxemia. Their PaO2 and SpO2 levels just aren't quite where we need them to be. The first thing you could do is to try to increase the FiO2 setting. You can increase the FiO2 up to 60% to see if it fixes the issue. If not, and if the patient is still showing signs of hypoxemia, this is when you would want to initiate PEEP. And finally, the last setting that we need to discuss is the ventilator alarm.
There is a separate, detailed video on ventilator alarms that you can find on Whollymedicoholic ICU's page.